Good morning, everyone.
Good morning.
So, to begin, kind of as Bruce mentioned, to start off the Grand Rounds, kind of like lecture series, I chose to talk about cellular-based therapies for OA. And Dr. Edward Rosero, who's an alumni of our program currently at Rothman, was my advisor on this talk. So I just want to give him a quick shout out. So to start off, still no financial disclosures, unfortunately. Sad face. Hopefully in the future. Just kidding. So objectives of my talk today, I want to define what a MSC or mesenchymal stem cell is. I want to provide support in terms of their clinical use and for specifically osteoarthritis, focusing primarily on bone marrow and adipose tissue. And then towards the end, we'll talk about extracellular vesicles and how they can be therapeutic targets in terms of treating OA and also other disease conditions. So kind of an overview, we'll answer the question of what is osteoarthritis, how do we traditionally treat it, and then kind of fast forward more to the future or current present day, I should say, alternatives. So bone marrow aspirate concentrate, adipose-derived stem cells, and then extracellular vesicles. All right, so osteoarthritis, we've all seen it. The most common kind of joint disease worldwide, estimated about 10 and 18% of women over the age of 60 have it. And then incidence, or I should say prevalence, as time goes on, the older you get, the more likely you're going to develop it. Within developed countries like the US, Canada, other European countries, they estimate that it costs us 1 to 2.5% of our gross domestic product. And that's taking into account, lost work days. Obviously, OA can be very debilitating when it's super severe. So they tried to capture that in this quote or this figure. So what it is, characterized by subchondral bone sclerosis. So if you look at the radiograph, you can see the bright white, primarily in the lateral compartment, but also you have medial compartment OA. Whenever bone is exposed to abnormal stress, it compensates by trying to beef up that layer. So that's where that sclerosis comes from. You can also get synovial inflammation, degradation of your cartilage, calcification of ligaments, and then osteophytes. So you can see kind of laterally, little lip sticking out would be an osteophyte. And there's more to it though than that, just mechanical issues. There's multiple inflammatory mediators at play that we'll see on the next slide. And traditionally the way we treat it is focusing more on symptom relief. So can I make you feel better versus actually modifying the disease? So this slide was a figure taken from a Lancet review, and kind of the takeaway message I got from it is really how much is going on in a pathogenic joint with osteoarthritis. So in the left-sided figure, healthy joint, you can see the structures preserved. You have your bone, your cartilage, the articular cartilage with the 3 layers, deep, middle, and superficial. Within that, you have your synovial joint fluid. And then looking to the right, you have your osteoarthritic joint. So you could see that the articular cartilage now has fissuring. It's very irregular. It's hypercellular. So you have all these little cells here secreting multiple factors, TNF alpha, interleukins, TGF beta, and there's all this crosstalk going on between all these cells, causing primarily the pain that we feel or patients feel when they have OA. So this was taken from the CDC website, kind of shows us the prevalence when we look at present day and then incidence, how many more people are going to get it in the future. I think this was from 2015. So if you kind of look up at that time point, they had approximately 54 million people diagnosed. I'm sure it's an underestimation because not everyone sees a doctor. And then present day for us now looking today, they estimated 63 million people would have it. But as you can see, it kind of linearly increases as time goes on. A lot of this has to do with, people aging, living longer, more likely to develop it. Obesity, obviously, risk factor associated with OA, inactivity, things of that sort are going to make the prevalence of OA, more and more common as time goes on. All right, and then kind of going into the background in terms of structure and function of our articular cartilage. So cartilage is very dynamic. It's not a static structure, constantly changing. The components primarily are type 2 collagen, so it provides kind of this meshwork providing tensile strength. There's different proteins and collagen fibers within, and kind of depending on what layer you're at, they may be oriented in a different way. You have proteoglycans, specifically aggrecan, and what that does is kind of provides that cushioning effect, so resistance to compressive force, draws in water, kind of keeps it lubricated. And then chondrocytes, so that's the only cellular component contained in articular cartilage. And chondrocytes kind of serve this regulatory role because they are responsible for both making all these extracellular matrix proteins, but also are involved in the degradation of it. So very important, but there's not very many of them. The cellular content is pretty minimal, the cells of the total tissue volume is pretty minimal. It's like 1 to 2%. And what articular cartilage does, it protects your underlying bone, subchondral bone, reduces friction as you move. So like thinking about your knee when we range it and extension and flexion, redistributes daily load. So as we walk, as you jump, if you're playing sports, run, etc., you need that cartilage there to kind of help you move freely and pain-free. And an issue that we always see is that the healing capacity intrinsically of cartilage is really bad because it doesn't have a great blood supply, or really no blood supply. There's no real nerves, no lymphatics. So how do you get stuff there? It's primarily carried in the synovial fluid. So as you move your knee, it sort of helps to distribute that stuff. But again, the potential is pretty limited as is. So this kind of just shows you a treatment algorithm, kind of more traditional in terms of how we treat OA. And if you start kind of at the bottom rung here, we always want to encourage things that are less invasive. So things like weight loss, exercise, physical therapy, things of that sort. So non-pharmacologic means, then kind of bumping up into medications. So you're thinking like NSAIDs or Tylenol or acetaminophen. Usually reach for that first, given that NSAIDs have renal side effects, have GI side effects. And they did do a Cochrane review, I think it was in 2006, and actually showed that NSAIDs were better than Tylenol for the treatment of OA, but because of the side effect profile, usually Tylenol is recommended first line. After that, there's supplementation, glucosamine, chondroitin. Opioids, they have been considered in the past, obviously something that you want to reserve given the high abuse potential, kind of epidemic that we have at present day. And they had the SPACE trial where they compared opioid versus non-opioid pain meds for chronic low back pain and then hip and knee OA pain. And then I think it was randomized controlled. They did find that non-opioid meds were not worse than opioids. So even more kind of reason to reserve those and try not to use them. And kind of stepping up, you have more invasive procedures. So corticosteroid injections or hyaluronic acid. Corticosteroid, usually, quick hit, anti-inflammatory. So the patient may feel better quickly, but typically shorter term pain relief. And within like a year time frame, you don't want to go really over 4 injections annually. HA, I would say, is safer, better side effect profile. It's visco supplements. So when you inject it in, it kind of provides, I think, like a cushiony kind of lubrication to help with the OA. And then kind of like last line or end stage OA, the thing you thinking of then is, well, I can't make you feel better. So the next step is I'm going to cut it out. And that's where surgery comes into play, usually total joint arthroplasty. So literally taking off for the knee, for instance, the femur, the tibial portion of the arthritic joint and the patellofemoral. So you're literally hacking out all the diseased tissue and putting in metal implants. There's other types of procedures, resurfacing procedures, but really that's the mainstay for osteoarthritis. All right, so kind of progressing to kind of more cutting edge stuff. What is a mesenchymal stem cell? So the gentleman on the right, this is Dr. Arnold Kaplan. He's a PhD from Case Western, kind of considered the grandfather of the mesenchymal stem cell. So he introduced this concept back in '91 when he talked about quote unquote cell therapy. And he identified, these cells, these mesenchymal stem cells that have the capacity to differentiate into different cell types, bone, cartilage, fat, etc. But as in doing so, they also remained immature, so they could divide one would mature into whatever cell, and then they would stay immature, another one, so it can self-renew. The ability to differentiate multiple tissues, so they're multipotent versus pluripotent. Maintain tissue homeostasis and tissue repair, primary functions, and where they come from. So bone marrow, adipose, which will be our focus. Also umbilical cord is another one. And with anything, when it's new, kind of a lot of people sort of jump on the bandwagon, they want to study it, which is great because it kind of advances science. But the downside is there's no real like standardization. So if that's not there, then you can't really compare study A and study B, because are you really giving them the same type of cells? So to kind of address this issue, the Society, International Society for Cellular Therapy, try to come up with these guidelines to sort of guide future researchers in terms of like these are the criteria that these cells should meet in order to be considered an MSC. So plastic adherence, these different cell markers, and their ability to differentiate. All right, so this slide kind of just shows pictorially that multi-potentiality. So you have your MSC here. It can divide and then split, creating still remaining immature and having the potential to further differentiate. And then here you have different lineages that it can turn into. So skin, neuron, cartilage, fat, bone, muscle, so on and so forth. All right, so then focusing in terms of what we care about more, kind of like musculoskeletal, the MSCs are actually found in multiple places, not just bone marrow. This is from a Nature paper that kind of reviewed native MSCs, and you can see they're kind of everywhere within the joint. So synovium, synovial fluid, fat tissue, the periosteum, the cartilage. This extraosseous MSC can differentiate into different types. And then here you can see the HSC, or hematopoietic stem cell. These coexist with bone marrow MSCs. They talk to each other. They kind of regulate one another, and they are able to differentiate into different cell lines. So they work very closely with one another, kind of just naturally. And so this slide kind of recognized, or excuse me, this study, I should say, recognized another role of MSCs. So they don't just divide and turn into different types of cells, but they also secrete all these different factors. And this is not an exhaustive list, but just looking at it, you can tell there's a lot involved, and they all serve different functions. So they can modulate your immune system, turn it down, turn it up, anti-apoptosis, so keep cells from expiring, angiogenesis, new vessel formation, support growth of other progenitors, anti-scarring, and chemoattraction. So like if in a site of injury, they can recruit further cells by releasing these mediators. So all the cell-to-cell communication. And this is kind of a throwback to early on, like cell biology. So different ways that cells communicate with one another. And the MSC functionality primarily use autocrine and paracrine. So autocrine is when the cell is releasing something, but that signal itself is acting on the MSC itself to do something. Paracrine is kind of more close range, like neighboring cells talking to one another. And then you have your gap junctions and endocrine, so you're acting on something farther away downstream, but using the bloodstream as a vessel to get there. But for MSCs, we're focusing mainly on autocrine and paracrine. Okay, so moving forward, bone marrow stem cells. So this population is very small in terms of the stem cell content within the marrow. You can see 0.001 to 0.01% of the total. And like I said earlier, they coexist with hematopoietic stem cells, control tissue remodeling, homeostasis of adipose, and then bone repair following fracture. Where you can get them in terms of clinically. So main places we think of are the iliac crest, either anterior, posterior, superior iliac spine. Other places as harvest sites are the proximal humerus, distal femur, proximal tibia. These usually are used in like orthopedic surgery application. So like, for instance, if you have a rotator cuff repair and you're looking to augment healing, you would use the proximal humerus because you're already in the shoulder joint. So you wouldn't have to make an extra incision to harvest the BMAC. You can just get it from the proximal humerus. And also for like the distal femur, if you're doing a distal femur fracture, you have cells there that you can harvest and use if you'd like. Oh, and one thing to note too, for bone marrow, there's a correlation with age. So if you're older, you're going to have less cells, less robust. Younger patients, more cells, more robust. Something to keep in mind when you think of who you may offer a treatment like this to, because studies have been done to show that with age, basically your cell population deteriorates over time. All right, so kind of getting into some primary literature. So this group studied adult goats and stem cell therapy for the treatment of OA. And what they did is they took goats, they had a control, and in the treatment group, they used hyaluronic acid as a vehicle to get the cells into the joint. The way they created the OA is they surgerized the goat. So they went into the knee, they took out the medial meniscus, and they resected the ACL. And here's kind of a study timeline. Here at week 0, they did the surgery. At week 2, they exercised them and actually put them on treadmills, I think, for an hour, just to like simulate loading within that OA joint. They harvested from the iliac crest, and they actually transfected green fluorescent protein into the MSCs. And so what that would do is allow them to, once they took biopsies down the road after they inserted the cells back in, could look histologically to see if the meniscus lit up. So with the MSCs that we put in there, did they integrate into the meniscus? And it did. So that's what kind of here shows. Let's see, box D and box E were actually the regenerated meniscus that they found within the goats. And then, as you can see here, B, C, there's a pretty robust population of the MSCs within the cartilage that was biopsied post-procedure. So I thought that was pretty cool that they were able to show how MSCs kind of integrate back into injured tissue. All right. So the next study done by Gobi and colleagues, so they did this surgical procedure, matrix-induced autologous chondrocyte implantation. Big name. Basically what it means is it's a 2-step procedure. You go in, you biopsy cartilage, you grow it in lab or expand it, and you can implant it into a matrix and then put it back into whatever defect. So in this study, they looked at specifically isolated chondral defects. They compare that to multipotent stem cells. So this one was bone marrow. So again, the site that they used to harvest was the iliac crest. And here kind of shows the steps that they did surgically. So in both groups, they did an arthroscopic procedure first. They evaluated the defect that they saw on MRI, and they were able to directly visualize. And then kind of progressing here, this is the BMAC group, A, B, C, D. This was the chondral defect repaired. B is the clot that they formed from the BMAC. So they took out the bone marrow aspirate. They applied this enzyme to kind of turn it into this clot material. They implanted it in a scaffold, and that's seen here in C and D, where they actually put that scaffold plus BMAC back into the defect. And they did MRI scans, I think it was a year out, and showed that both the MACI group and the bone marrow stem cell group were able to kind of regenerate or have this graft incorporated into the chondral defect. All right, so next, this study looked at the clinical outcomes of bone marrow for OA of the knee. It was a case series, 41 patients. Again, they harvested from the iliac crest, either anterior, posterior, superior iliac spine. And they also used unprocessed fat The thought being it served as like a scaffold for the bone marrow aspirate concentrate to attach to and then further propagate. They also looked at patient report outcomes, so like the VAS score, IKDC. It looked up to 12 months post-procedure, and they also evaluated people with X-ray. And based on KL grade, they kind of broke it down in terms of who responded the best, because they all actually responded well. And kind of like this figure demonstrates that people with less severe OA based on their KL grades, so that's just looking at how severe is your arthritis, how narrow is the joint space, osteophytes, et cetera, 0 to 4. So if you have less severe disease, the more likely you're more likely to benefit from the BMAC procedure. So I think that's important when we think about who we're going to offer this to. All right, so kind of going into just some technical things, how BMAC is done. So, obviously sterilely in the operating room under ideal conditions. You have your anesthesiologist here. You can do it under local or general or conscious sedation. You sterilely prep and drape. So you have your surgical site here. So you can see she's prone, padded appropriately, and you're going to go after her PSIS. You have your BMAC kit here. And this kind of just outlines step by step what's happening. So you want to palpate your bony landmarks, inject local anesthetic, and you wanted to avoid using epinephrine because that can degrade kind of the stem cell content that you get. You have like a cannula with a needle that you can, after a stab incision, push down. And once you get to like cortical bone, you can attach to a power tool like a drill to get through that and get into the marrow portion. And when you aspirate, you're usually taking about 60 cc's. I've seen as high as 120. And once you have that, they have these dedicated machines that they centrifuge. I think it's like a 2 or 3 step process to isolate the BMAC itself. And then once you have that, you can, inject accordingly. So like in the peripheral joint, like the knee, maybe they have bone marrow edema. So that's something you wanted to address with the injected as well. That's a picture of kind of like what the kit looks like. And here's just sort of a step-by-step of what it looks like. So he's palpating, he's injecting the local, using the trocar by hand. And once he fills the cortices, you can attach to the tool and really get in there. And a person who I've seen done this told me that rather than just going in once and then pulling out the whole 60, to try and do like multiple injection sites. Because some studies have shown that actually improves the yield that you get within the stem cells. All right, so moving on to adipose. Normally when we think of adipose, right, it's like high energy, you're not working out, and you're eating a lot, so you have all this storage, metabolic reservoir. In the 80s, they realized that fat does more than just that. It's involved in metabolism of sex steroids, so like aromatase, turning it into estrogen. Present day, we think of it also now as a site for stem cells. So this picture here kind of like shows graphically where the stem cells kind of reside in relation to other tissue components. So you have your adipocytes, your surrounding blood vessels. When you actually harvest this and you process it, that's called the stromal vascular fraction. And within that stromal vascular fraction, there's multiple cell types. So you have your adipose-derived stem cells, other progenitors, white cells, lymphatics, pericytes. And the way you kind of isolate the adipose, there's like centrifuge, but also another technique I'll talk about that just uses gentle kind of like disruption with these steel balls. The reason why adipose is nice compared to BMAC is that, one, it's easier to get. You can imagine if you're going in and you're puncturing somebody's iliac crest, that's going to be pretty painful. So there's a lot of donor site morbidity. Adipose, it's easy to access. So primarily your abdomen. When I've seen this talked about in clinics, patients, one thing they always bring up is like, oh, I get like a bonus of a liposuction procedure, which is kind of true because that's essentially what you're doing during the harvest. So just things to kind of like think about. Going into some studies. So in this study, they did a randomized placebo-controlled trial looking at adipose-derived stem cells, and they compared it to, I believe it was normal saline. And the controlled trial contained 24 patients, so not a lot. They used the BMAC score as the primary outcome, and they also did radiographic analysis with X-ray and MRI. This kind of just outlines how the study was done. So they screened 33 folks, included 24, split them equally. You had your adipose group and your normal saline group, followed them up to 6 months, and they did post-MRI and a follow-up and clinical follow-up. Found that, comparatively, the adipose stem cell group did do better in relation to the patient-reported outcomes. And then the other thing I wanted to mention is that for the MRI portion, they did include patients that had a focal chondral defect. And the point of that was, by using the MRI, you were also able to evaluate how did that defect progress, stabilize, or get better. So they found that in the stem cell group, there was stabilization of that focal defect. Like, it didn't get a lot worse. But in the normal saline group, it did get comparatively worse. All right. And then this study, another randomized controlled trial done by this group, primarily in Australia. And again, it was randomized, it was controlled, which is great. In the treatments arm, they had 2 stem cell groups. One group got 1 injection, the other one got 2 spaced 6 months apart. And then the control group was really just conservative management, so like pain meds orally, exercise. So not the ideal control. Ideally you'd want to inject something so maybe you can account for like a placebo, but they didn't have that. They also used MRI to evaluate, what did the cartilage do radiographically from pre-injection to post. They did note, like this group as well, both the treatment 1 and 2 injection got better in terms of the clinical outcomes. But when they look at the MRI and the X-ray, the 2 injection group had kind of stabilization of the disease where there wasn't more osteophyte formation. The articular cartilage didn't look worse radiographically, whereas both of them got worse. There was more osteophyte formation and worse looking articular cartilage on the control group. So the one that was only treated with like pain meds and exercise. Kind of extrapolating is, well, maybe giving, a serial injections is better than just one. But, can't really draw that because sample size is too small. That's just something that I was thinking when I read this. And this kind of just outlines the study, how they did it. So you have your control group and then the 2 treatment arms. All right, so this picture, when you think of like fat harvesting, really all this started, in plastic surgery. It was used as a filler for, facial reconstruction, breast augmentation, things like that. And then Dr. Sidney Coleman, he kind of pioneered a technique called the Coleman technique, which was you basically aspirated the abdomen to harvest the fat and then process it or whatnot and implant it accordingly. The ways to get the adipose, one, you can aspirate, you can do a liposuction type procedure, or you can actually cut it out, so direct surgical incision. For more the orthobiologic standpoint, you're primarily using more aspiration. So here's a patient prepped and draped, and you have your abdomen here. You make small stab incisions and you inject something called tumescent. So it's like normal saline, epinephrine, and I think it's lidocaine. And the purpose of that solution is to basically swell it up and make it easier to harvest. And you let it sit, kind of massage it in for like 10 minutes. And then you have this kind of like long cannula that you insert and sort of do these broad strokes throughout the abdomen. And just kind of like you have the syringe attached, you pull back so there's negative pressure. And once you're in, as you move, you're just kind of like slowly sucking out more and more fat. And over time, it'll get kind of more bloody. So the redder it is, meaning you're harvesting blood versus actual fat. That's kind of like a cue that you want to stop. So here's kind of what it looks like post harvest. As you can see in C, it's pretty red, so a lot of blood there. B was probably taken out much earlier in the harvest. And here's a sort of canister that this group used to, this is like a technique paper. And you see here these little steel marbles. So they're containing this canister with the fat, and it's just kind of like gentle, literally like shaking it up and down. And the marbles just work to disrupt and release those MSCs, of which you can then concentrate in and inject into, you know, whatever site you're trying to treat. I personally haven't seen this, but I thought this was pretty cool, and you know, kind of using something just so kind of basic to achieve something. All right, so extracellular vesicles. What these are the way I think of them are kind of like what they call messenger pigeons. So they're literally like little buds of plasma membrane. So thinking back to, you know, biology back in high school, your plasma membrane, you have the phospholipid bilayer. So you have your two hydrophilic heads. So they want to, you know, be around like water type, exposed to more water type environment. And then you have your hydrophobic tails that want to touch. So it serves as like this seal or this barrier. And they can contain all kinds of stuff, DNA, or not DNA, excuse me, RNA, mRNA, proteins, etc. And they're involved in cells talking to one another. And like this kind of goes back to that slide with all those different secreted factors. They can be contained in these cells and are involved in, you know, the trophic ability of an MSC to do what it does. Categorized based on size, as well as like content of proteins. But here, for the regenerative medicine applications, primarily we're thinking of exosomes. So they're the smallest. Others you have are microvesicles, apoptotic bodies. You know, they can contain all of these different contents, as well as have, you know, different cell surface receptors, transmembrane proteins. So that can be involved in like honing, like it'll help the exosome get to where it needs to go. And this slide kind of just shows you graphically how that works. So you have your bilayer here, your plasma membrane, within it all these different transmembrane proteins. Once that buds off, within this kind of inside the cell, you get these what are called intraluminal vesicles that create these exosomes, and then as they progress, it can then attach to the surface and then exocytose or release all those exosomes out into the environment. And they've been shown to, you know, be protective, so whatever it's carrying isn't going to get chewed up by all the proteases and different enzymes that are floating outside here. So that's why I think of it kind of like a messenger pigeon. And this slide just kind of shows generally what, this is all in animals, so no real human trials. But in animals, kind of like a summary of what they've shown exosomes to be able to do. So in OA, you know, in vitro, improve cartilage anabolism, so like build up, decrease inflammation. In mice, it can protect against cartilage degrading and from OA getting worse. Addressing joint inflammation, so immunomodulation, all those different factors that we previously talked about. As well as mice, you know, anti-inflammatory effects, you have reduced cartilage breakdown. And then in rabbits, you know, they have a defect repair with, you're able to address hyaline-like cartilage formation using exosomes. So this was I believe it was a Nature paper, basic science study, and they were able to show using a mouse model that these exosomes, as well as these microparticles, like different types of small proteins, were able to protect cartilage and kind of worsening of OA. They looked at, it was able to affect, what's it called, matrix metalloproteinases, and then Adams enzymes, different like inflammatory markers. They're able to slow down those from breaking down the articular cartilage. This slide just kind of summarizes really, exosomes or extracellular vesicles. They're not just specific to, musculoskeletal, chronic musculoskeletal conditions. They've been studied in a lot of different disease states, so heart disease, kidney disease, liver disease, lung disease, cutaneous wound healing. I did a quick search on clinicaltrials.gov, and I don't believe they're enrolling yet, but they're studying exosomes in terms of COVID, and not surprise given the current times. But if you think about it, like an exosome is really an ideal way to give like targeted therapy, so like gene therapy or different inflammatory mediators, because you can send it based on whatever protein it expresses on the surface. It can go to where it needs to go, and it's not going to get chewed up by the environment around it. So kind of like stepping back, what does this all mean? My takeaway was there's a lot of potential here. Studies, they're definitely supportive. I wouldn't say they're totally yet convincing, primarily because there's just not a lot of like large randomized controlled trials. They're difficult to do, obviously. Most of the studies I came across contain upwards of 50 patients. But I think more needs to be done to evaluate how good it is and how safe it is. Usually the side effects, they weren't minimal that I saw. It's primarily post-injection pain, which one would expect, but would resolve fairly quickly. There's always a risk of infection, but not very common. And then joint effusion is something that happened, but typically resolves in a few days as well. When you're thinking about who you're going to offer this to, I would say people that probably are younger. They're more likely to respond better if they have less severe OA. Another thing to consider too is like patients who are elderly and are thinking about surgery. There's implant life. So if an implant lasts like 15 to 20 years, you don't want to be 50 years old getting a knee replacement, because that means you're probably going to have a revision surgery to exchange the polyethylene liner, because it's not going to last forever, especially the more active you are. It's going to break down eventually. So those are just things that you want to have in mind in terms of who you're going to offer this to. This is just a slide that I took from the FDA, and it lists all the current like FDA approved cellular products, and they're primarily all cord blood, so not like OA type issues, but more for leukemia, lymphoma treatments, things like that. So this is has yet to be approved, but it is actively studied. There is a FDA approved RCT that's underway. And then within clinical trials, I just searched MSC and OA, and currently there was 112 studies listed that are either actively recruiting or ongoing or have recently been completed. All right, so this is a list of my references, and that is it. Thank you.